Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good morning to everyone. Let's begin our CME this morning with Ummul Kitab Al-Fatihah. Okay, Alhamdulillah. So today it is my pleasure to welcome all of you for our today's CME session. And as we all know, cardiovascular diseases remain one of the leading causes of morbidity and mortality worldwide. And acute ST elevation MI is a time-sensitive emergency that requires prompt recognition and elimination to improve patients' outcomes. So in primary care, our role in recognizing Stemi early and initiating the right course of action can significantly impact the patient's survival. So today's session serves as a refresher to reinforce our knowledge and clinical judgment in managing Stemi based on the 2019 Malaysian CPG on Stemi. While there have been no major updates since then, but we must continuously revisit and refine our approach so that we can ensure the best clinical decisions that are aligned with the best available evidence. So today, it is my honor to introduce our speaker, Dr. Salmani Ravichandran. Let me introduce a bit about the background of our speaker. Dr. Salmani completed her medical degree at Kurs State Medical University Russia in 2017, and she subsequently underwent housemanship training at Hospital Pulau Pinang from 2017 until 2001. After that, she continued her medical services as medical officer in the emergency department Hospital Pulau Pinang until 2020, and this is followed by posting at the Hospital Sungai Siput until 2022 before she joined us in our master's program. So without further ado, let's welcome Dr. Salmani to begin her presentation. Okay, Dr. Salmani, are you there? Can you share your slide with us? Because I can't see Dr. Salmani. Can you all hear my voice? Because I can't see any response.
Sorry, Dr. Soiza. Yes, I'm sharing my slide right now.
Okay, thank you. Can anyone share also the attendance list for today's CME?
Good morning. Can everybody see my slide?
We can't see anything yet. Can you try to share again?
Right. Can everyone see my slide right now?
Okay, Salmani, your slide is on the platform already, so you can start your presentation.
Okay, thank you, Associate Prof. Dr. Suhaiza. Good morning, and thank you for all doctors who are attending our online CME session today. I am Dr. Salmani Ravichandran. So the topic that I'll be sharing with all of you today will be STEMI in primary care recognition and the early management. So these are the contents that I'll be talking about today. So our definition of acute coronary syndrome, diagnosis of STEMI, cardiac biomarkers role in STEMI, pre-hospital and inpatient management, what is STEMI network, reperfusion strategies, complications of related to STEMI, risk stratification post-STEMI, and how we do secondary prevention post-STEMI. So now this is the introduction. So based on our recent publication of National Heart Association, NAM and Minister of Health Malaysia in 2024, shows that ACS registry 2020 up to 2021 is up to total of patient 15,162. So out of them, 50.3% was cases with ST elevation MI, 30.4 was non-STEMI, 19.3 was unstable angina, which should markedly increase compared to the previous years. So in mean age of patient with STEMI at presentation was 56 years old and above, and 86.5 of them was male. So the mortality rate due to STEMI appeared to be increased compared to the previous years. So now the definition of acute coronary syndrome. Acute coronary syndrome is the clinical spectrum of coronary artery disease, which is further classified into unstable angina, STEMI, and non-STEMI, based on degree of coronary occlusion. So the topic we're going to talk today is about touching more on STEMI. So now, diagnosis of STEMI, according to our CPG, our latest CPG was like 2019 STEMI CPG. So MI is defined pathologically as myocardial cell death due to prolonged ischemia. So it's diagnosed when there is a raise or a fall in cardiac troponin, at least one value above 99 percentile, and it must be accompanied with at least one of the following, which is our clinical history consistent with chest pain of ischemic origin of more than 30 minutes, or ECG changes of ischemia, infarction, or the development of pathological Q wave, or imaging evidence of a new loss of viable myocardium or new regional wall motion abnormalities, or that's the identification of thrombus by angiography or when we are doing autopsy. So what about ECG findings? So according to CPG, STEMI is diagnosed when there is ST elevation more than 1 mm in two contiguous leads, or a new onset of left bundle branch block in the resting ECG. So now this is a diagram on how a clinical spectrum of AC has been classified further. So when we receive a patient in either in a primary care or in tertiary center, a patient presented with ischemic chest discomfort, the first provisional diagnosis that all of us will thought of is definitely ACS. So as we receive a patient with chest pain, we will be starting to do ECG. So then further, if our facility is occupied with cardiac biomarkers, we'll proceed with cardiac biomarkers and then the final diagnosis will be done. So in case of ECG with no ST elevation, we will further classify them based on cardiac biomarkers. If it's normal, then the diagnosis will be unstable angina. If the cardiac biomarkers is elevated, then we will diagnose as non-STEMI, whereby when ECG is ST elevation and cardiac biomarker together elevated, then we diagnose the patient as ongoing STEMI. So now, what are the targeted history important to diagnose STEMI? As we all know, the first typical symptoms patient will present to us will be definitely pain over the chest region. So for a STEMI, the pain will be usually begin abruptly and last for at least more than 30 minutes, and located in the center of the chest and may radiate to the jaw or down left arm and may occur at rest or with activity. And the characteristic will be pressure, squeezing, and severe in nature. Severe crushing pain in nature. So the pain may be burning quality, or even patient will come in with localized to the epigastria or interscapular region. So most of them will be associated also with sweating, nausea, vomiting, and shortness of breath. But always remember, there are certain patients who might not present to you with pain over the chest region, just simply will come with atypical symptoms such as like fatigue, shortness of breath, dizziness, lightheadedness, and unexplained sweating and syncope. These are mostly common in elderly patient with multiple morbid, as well as patient with diabetics. So what's next? Definitely after the patient complaint of having chest pain, a clinical suspicious of ACS will be there. So a 12-lead ECG should be performed and interpreted immediately within 10 minutes of first medical contact. So always bear that in your mind. The initial ECG in MI may be normal, equivocal, or show hyperacute T wave changes only. So if suspicion of STEMI is high, the ECG should be repeated at close intervals of at least 15 minutes to look for progressive ST changes. So before we move on further, let's have a look and refresh ourselves on our basic ECG. And then where we'll be having like PR interval, PR segments, QRS complex, ST segment, and QT interval. I'm very sure that we all are very familiar with all the segment and PR intervals. The main reason of me putting this slide on today is because let us refresh on J point. So what is J point? So J point is actually the end of the QRS complex, and the starting junction of the ST segment, sorry. So this is the place that we have to really notice when the patient when coming with chest pain, because here the changes in ST elevation and ST depression will be seen if patient presented with STEMI. So now moving on next, evolution of STEMI. This is the reason why a patient might present with a normal ECG or just hyperacute waves during the first presentation of chest pain. So when there is the occlusion of coronary occlusion occurs, the first changes of ECG will be hyperacute T wave, which occurs from minute to hours. Subsequently, it becomes ST elevation within 0 to 12 hours, and then Q wave developing from 1 to 12 hours, and it will become ST elevation with T wave inversion within 2 to 5 days. So when the patient present to us, the patient might be presenting at the point like they have the acute coronary occlusion during the minute to hours. So they might be present with just the hyperacute T wave. So now this is a table on summarize the location of MI with the leads involved and the changes in the ECG. So now, for example, anterior septal MI, we might see the ST elevation in lead V2 to V3. For extensive anterior, we might see the ST elevation almost in all lead V1 to V6. And then for posterior ECG, ST elevation from V7 to V8, whereby in V1 to V2, we'll see ST depression. For an anterolateral MI, we can see the ST elevation in 1 AVL V5 to V6. For inferior MI, we can see the lead changes in lead 2, lead 3, and AVF, whereby for a right ventricular, we will see in right-sided V4 lead. So this is actually a very interesting, colorful visual diagram, which is actually the summary of the previous table. So this is actually the MI location and leads involved as lead involved for our easy remembrance. So each colors showing the particular leads involved in the MI location. So now there are a few things that we have to take note when patient come in with a STEMI or chest pain. So always remember, a patient with new presumed right bundle branch block accompanied with ST segment elevation, please treat as STEMI. So patient with inferior STEMI, please do a right precordial lead to identify the right ventricular involvement. For if there is ST depression in lead V1 to V3, please proceed with posterior chest wall ECG to identify the inferior basal STEMI. And patient who present with ST elevation of more than 1 mm in lead AVR may accompany anterior or inferior STEMI. So now a previous slide I've been mentioned about the posterior ECG and right-sided ECG. So here's how we'll be putting the leads on. So this is actually the repositioning back of our precordial leads on anterior chest lead, which is V4 to V6. So we'll be putting V7 under a posterior axillary line. V8 is a tip of the scapular line, and V9 is actually left paraspinal line. What about right-sided ECG lead placement? Actually, it's similar to the position when we put the normal routine ECG. It's just a mirror reflection position back of our routine ECG. So now, moving on next, what are the role of cardiac biomarkers in STEMI? Sorry. So it's a raise and fall in level of serum cardiac biomarkers actually support the diagnosis of STEMI. And most of the cardiac biomarkers here we are familiar with, like CKMB, troponin I, troponin T, CK, and myoglobulin. So this usually arise first detected hours after the onset of symptom. And troponin and CKMB are the cardiac biomarkers of the choice. But bear that in your mind, do not always rely on your cardiac biomarkers. If our primary care is not equipped with cardiac biomarkers, please proceed with the final diagnosis based on your clinical judgment as well as our ECG finding. So now we are moving on to the pre-hospital management. So in STEMI, time is myocardium. So in STEMI, it's important for us to reduce total ischemic time, the time from symptom onset to the time of institution of reperfusion strategies. So what are the total combination of the ischemic strategy? So the total ischemic time is combination of time from arterial occlusion to the symptom onset, from the time from onset of symptom to first medical contact, and first medical contact to initiation of reperfusion strategy. So now this is in case of patient we receive a patient with chest pain in our primary care center. So as a pre-hospital care provider, attend a patient with chest pain, first is important history taking. So identify the chief complaint and proceed with ECG. So concomitantly, do not forget your ABC. So airway, breathing, and your circulation is still important in reassessing our patient with chest pain. So ensure the patient's airway is patterned. Assess the patient's respiratory status, provide oxygen if SpO2 is less than 95%, and then assess vital sign, monitor the blood pressure, heart rate, and respiratory rate. Insert 2 large bore Branula. And then subsequently, once we get the ECG and it's confirmed a STEMI, then patient should be given a soluble or chewable aspirin 300 mg and tap clopidogrel 300 mg stat and 1 dose of sublingual GTN by tablet or spray. So please avoid giving GTN if you notice the patient's systolic BP is less than 90. So then the patient should be rapidly transported to the hospital for early initiation of the reperfusion strategy. And if the anticipated time from the first medical contact to the PCI mediated reperfusion is more than 120 minutes, then pre-hospital or nearest hospital fibrinolysis will be the option. So now here, when the STEMI networks plays the role. So what is STEMI network? So STEMI network is to link non-PCI capable center to PCI capable center with the aim of providing PCI services in timely manner for the patients. So with STEMI who have given fibrinolytic therapy and failed the reperfusion, or as a part of pharmaco-invasive strategy, or patient who have high features requiring the early intervention. So now STEMI network is in Malaysia is still available in Klang and in Pahang. So in Pahang, there's 2 established pre-hospital STEMI network, which is like a Kuantan Pekan Rompin network, PCI network. Temerloh Maran network is a non-PCI network. So this is our map showing all the hospital which is involved in a PCI and non-PCI network. Mostly all our KKs and our hospital is directed to a PCI or non-PCI center. So this is our Pahang STEMI network 2020 up to 2025. So moving on next, Pahang pre-hospital reperfusion strategy of choice of acute STEMI. So as we receive a patient with chest pain to our KK with onset of chest pain within 12 hours, so the diagnosis of acute STEMI should be made. And if the patient is actually presented to non-capable PCI within a non-capable PCI network, the thrombolysis decision will be done by EP. Subsequently, if the thrombolysis decision is being made, so the thrombolysis will be administered at KK, and then early transportation to the nearest hospital post-thrombolysis will be done. So if a KK without ambulance, we have to wait for the retrieval team from hospital to come and take the patient to the ED. So if hospital KK with ambulance, so patient can be sent straight post-thrombolysis to the ED. So if the patient arrives within the PCI capable network, then STEMI network group will make the decision for if patient is being proceeded to primary PCI, then patient will be sent to the activation of the cath lab will be done, and patient will be sent to the ED and cath lab for the primary PCI. So this is actually the summary of the Kuantan Pekan network as well. So similarly, once the patient with chest pain came to us with chest pain, the first is we have to initiate the ECG doing within 10 minutes. So and then manage accordingly, which is we have to give sublingual GTN, aspirin, clopidogrel, and ECG monitor will be done. And the decision of thrombolysis will be done. If patient is opted for a thrombolysis, so we will initiate the tenecteplase, IV heparin bolus, and we will be transport the patient to the ED of HDAA. So if option is a primary PCI, then patient will be sent as soon as possible to the ED HDAA within 60 minutes. So now a little bit on in-hospital management. So in-hospital management, we will be concentrating more on pain relief, establishing early perfusion, and treatment of complications. So now, as a patient, we receive a patient with chest pain to our ED. So we will triage the patient to the red zone. So once we triage the patient to the read zone, so a quick targeted history should be taken, followed by vital sign monitoring and ECG in 10 minutes of patient's arrival. Meanwhile, concomitantly, we have to also assess the ABC, ensure the patient's airway is better, assess the patient's respiratory status, provide oxygen if less than 95, and then or if there is evidence of respiratory distress or hypoxia, and assess vital sign, monitor BP, heart rate, respiratory, and in situ large bore granular. So if the patient is suspected of having STEMI based on history, but without any obvious ST elevation, kindly repeat the ECG at 15 minutes interval. So once you confirm the patient been having STEMI, please put the patient on ECG monitoring. So then next, we will be giving the patient aspirin and clopidogrel 300 mg stat with 1 dose of sublingual GTN by tablet or spray and avoid it if SBP is less than 90. And then alternatively, we actually can give 300 to 600 mg of clopidogrel or 180 mg of ticagrelor given as loading dose if primary PCI has been considered. So for pain management, IV morphine at 2 to 5 mg bolus can be given as necessary. But meanwhile, doing all these steps, do not forget to take your basic routine blood and cardiac biomarkers. So then bear that in your mind, IM injections and NSAID should be avoided in patient in STEMI. And then subsequently, patient will be assessed for suitability of reperfusion strategy. So now, always remember, the reperfusion strategy of choice is still primary PCI. So what to consider? So the time from symptom onset to the first medical contact, time to PCI, time to hospital fibrinolysis, contraindication to fibrinolytic therapy, and high-risk patients. So now this is a flow chart how management of STEMI, how management of patient presenting with STEMI. So how the reperfusion strategy will be decided based on patient. Okay, so as a patient came in with chest pain, we will definitely give the first initial management like ECG, aspirin, clopidogrel, analgesic, and oxygen if indicated. So the first thing we have to take note is the onset of symptom. So if a patient present to us with less than within 3 hours, so preferred option will be primary PCI or fibrinolytic therapy. So if a patient presented to you in 3 to 12 hours, primary PCI is still the preferred option. But in case patient presented to a non-PCI capable center, then fibrinolytic will be option. So if a patient came more than 12 hours to your center after chest pain, so there will be medical therapy and antithrombotics will be given. But if the patient persistently having ischemia or hemodynamic instability, then primary PCI can be considered. So now this is for a primary PCI. We'll be having a target from first medical contact to wire crossing so that we can actually able to bring the patient to PCI. So for example, if a patient was initial came to the PCI capable hospital, so the target time from first medical contact to the wire crossing duration will be less than 90 minutes. If a patient presented to a non-PCI capable center, then we expect the patient target time from first medical contact to the wire crossing within 120 minutes. So for the third one, the yellow one, the door 1 ED of the spoke to the first medical contact, which means from the first patient came to our ED to the first ECG done should be within 10 minutes. So door 1 ED of the spoke to departure, which means from the time patient been seen our ED to departure to a PCI capable center should be targeted within 30 minutes. And then the following, door 1 ED of the spoke to door 2 ED of the hub travel time is less than 60 minutes, which means from ED of the non-PCI capable center to the ED of the PCI capable center, we expect patient to reach the center within 1 hour. Whereas from the door 2 to ED of the hub to the wire crossing, we expect once the patient reach the ED of the PCI capable center, wire crossing can be done within 30 minutes. What about fibrinolysis? If a patient transferred from a non-PCI center to a PCI center, so we expect the patient to reach within less than 90 minutes. So if a ambulance is transporting direct to the PCI center, we expect patient to reach within 1 hour. So this is actually the summary of the previous onset of chest pain to the time of wire crossing. So always remember, if there is the time interval transfer anticipated to be longer than stated, please initiate your fibrinolysis first and then consider the same day transfer for the PCI as the part of pharmacoinvasive strategy within 3 to 24 hours. Or for transfer later, but depending on the clinical condition of patient and available resources. So now about a little bit about fibrinolytic therapy. So actually, it reduces mortality when given within 2 hours from time of onset, time of onset of the symptom, the golden hour. So the most beneficial and has been shown to be able to abort the infarction and reduce mortality by up to 50%. And the dawn to needle should be within 30 minutes. So now these are the choices of fibrinolytic we are actually familiar of. So we have streptokinase and methylase. So streptokinase regime is a 1.5 mega unit will be diluted in 100 ml of normal saline or 5% of dextrose over 1 hour. So tenecteplase, or we usually known as methylase, given as a single dose, it's a weight-based regime. So in a patient 75 years old and more, the dose should be reduced by 50%. So anticoagulant with heparin or enoxaparin administered immediately after the completion of fibrinolysis. So these are the absolute and relative contraindication for fibrinolytic therapy. So absolute contraindication are such as like a history of ICB, history of ischemic stroke within 3 months, known structural cerebrovascular lesion, known intracranial neoplasm, risk of bleeding, active bleeding or bleeding diathesis, significant head trauma within 3 months, suspected aortic dissection. So relative contraindication when this patient is risk of intracranial hemorrhage, severe uncontrolled hypertension, ischemic stroke more than 3 months, history of chronic severe uncontrolled hypertension as well. So it is also contraindicated when patient has a high risk of bleeding. So like patient like a recent major surgery less than 3 weeks, traumatic or prolonged CPR more than 10 minutes, recent internal bleeding, non-compressible vascular puncture or active peptic ulcer. It is actually also contraindicated in high-risk patients such as like patient with anterior infarct, hypertension and cardiogenic shock, significant arrhythmia, elderly patient, post-risk vascularization like post-CBG and post-PCI and post-infarct angina. So now, once we have given the patient the fibrinolytic therapy, what are the indicators of successful reperfusion? So patient will have resolution of chest pain, early detent of ST segment elevation to the isoelectric line, or the decrease in the height of ST elevation by 50% within 60 to 90 minutes of initiation of the fibrinolytic therapy. So early peaking of CK and CKMB level, and also the restoration and maintenance of hemodynamic stability. So now, how to know if fibrinolytic therapy failed? Most of the time, by the time patient have a failed fibrinolytic therapy, patient would have already reached hospitals. But how do we know if a patient having fibrinolytic therapy failed? So patient will still having ongoing chest pain and persistent hyperacute ECG changes whereby there's no ST elevation resolution, hemodynamic and electrical instability. So here we have to initiate rescue PCI within 1 to 2 hours of after failed fibrinolytic therapy. So if the patient presented to our KK, so once we done fibrinolytic therapy and we notice there's a failed fibrinolytic therapy, please send the patient for rescue PCI within 1 to 2 hours to our tertiary center. So now, risk stratification post Stemi. So all the patient with Stemi should have an early assessment of short-term risk. So this actually can be done using a Stemi score and risk score. So what are the important consideration here? So an evaluation of extent of myocardial damage, the occurrence of successful reperfusion, and the presence of clinical marker predictive of high risk of further CV events. So patient also have to go on evaluation for a long-term risk by assessing the left ventricular ejection fraction, usually using by echo, residual ischemia by stress test, and occurrence of complications during hospitals, example, heart failure, arrhythmias, mitral incompetence, septal rupture, and left ventricular aneurysm. And also do not forget your cardiovascular risk factors. So now this is our Stemi score, which predicts the 30 days mortality. I think I'm very sure that everybody familiar with this Stemi score. So this is the categories will be included in Stemi score, where it's the age, weight, systolic BP less than 100, heart rate more than 100, Killip class 2 to 4, anterior ST segment elevation of left ventral branch block, diabetes or history of hypertension or history of angina, time to treatment more than 4 hours. So any 0.5 from below, we classify the patient as low and moderate risk. If any 6 points and above, then patient will be fall under high risk category. So now, what are the post-STEMI secondary prevention? So the prevention will be smoking cessation and other lifestyle changes, regular exercise, control of cardiovascular risk factors, hypertension, diabetes, and smoking dyslipidemia, as well post-STEMI drug initiation, our antiplatelet, statin, beta blockers, ACE or ARBs. So now these are the complications of STEMI, arrhythmias, left ventricular dysfunction, shock, mechanical complication like wall rupture, right ventricular infarction, and others like pericarditis. So now this is the end of our slide. So what are the take-home message from our CME today? So its early identification and diagnosis are crucial in STEMI. So a quick assessment and decision on reperfusion therapy can reduce the total ischemic time. So primary PCI should be prioritized as preferred reperfusion strategy whenever possible, and timely management of STEMI leads to better overall outcome. So now, thank you. If you have any question, you can type it in our chat box.
All right, thank you to Dr. Samani for enlightening us on the STEMI. I think now we can open question and answer to Dr. Samani. So, okay, I will read some of the question here on the chat box. This is from Dr. Yugeswari. Is fibrinolysis failure is common? Can Dr. Samani share with us how common is fibrinolysis failure?
So now, okay, fibrinolysis failure is actually quite common, and according to research, up to 40 to 50% possible chances of failure is there. So whenever you suspect there is a fibrinolysis failure, please kindly do not delay your time for PCI door to needle time. So please refer your patient for a rescue PCI. Yes, so if you have any doubt in during your fibrinolytic therapy, please kindly discuss the case with cardiologist on call. Yes, so it's quite common.
Oh, okay. It's quite high percentage. Just now you mentioned how many percent, Dr. Samani?
40 to 50% possible.
Okay. Because nowadays we also initiate fibrinolysis in primary care, right? There are some KK that have this neonatal place. All right. We have second question from Muhammad Yasir. Is fibrinolysis recommended in patient who recently received fibrinolysis within a year? So probably whether he is asking whether patient can have another dose of fibrinolysis in the same year.
Yes. Actually, according to our research as well, and also CPG, a patient who have been given any fibrinolytic therapy within a year is not recommended for another dose, in sense of there is no any good prognosis for the patient. So if the patient have previously been given fibrinolytic therapy within a year, so we have to think of PCI as the first preferred option. But however, if the patient actually presented to a non-PCI capable center and our transfer time is more than 120 minutes, it's advisable to start fibrinolytic therapy as a bridge to our PCI before we giving the patient PCI. So there's no harm of giving, but even just the efficacy will be a little bit lesser compared to the first initiation. So we usually prefer PCI.
Oh, okay. All right. The third question here. What are the common arrhythmia post-STEMI from Navin Kumar?
Okay. There are few common arrhythmia that we can see post-STEMI. For example, we can get patient with ventricular tachycardia, ventricular tachycardia, ventricular fibrillation, sinus ready, and even AF. But the most common is 86% is taken by our atrial fibrillation. So yeah, atrial fibrillation will be the most common according to our recent research, which was done like in 2023, stating that AAF is most commonly seen, even in patient during monitoring in CCU post-STEMI. So yeah.
Okay. We still have question here. The term facilitated and rescue PCI, are they similar?
Okay, actually it's not similar. Okay, rescue PCI means a PCI that where we will initiate once patient failed our fibrinolytic therapy, meaning when we give patient a fibrinolytic therapy and patient failed the fibrinolytic therapy, we will refer the patient for a rescue PCI. Whereas facilitated PCI is a planned PCI which will be done in a very controlled manner where we will be doing the fibrinolytic therapy first, and the facilitated PCI will be initiated in 3 to 24 hours. So it's like in a very it's in a very controlled manner. So it's not a rescue PCI. It's just to top up our fibrinolytic for a good prognosis.
Okay. Okay. Another question here. Duration of DAPT for patient post-MI. I think DAPT probably referring to dual antiplatelet therapy. Yeah,
Okay.
correct. Dual antiplatelet therapy. So the duration of this double antiplatelet after the MI attack. So how long is the patient should be on this medication, Dr. Samani?
So this question is a bit controversial because this is actually totally based on patient's clinical judgment. But the standard dosing of DAPT is actually for 1 year for all of the patient. But if the patient happen to be having any risk of bleeding, so meaning this patient is actually a high prone patient for bleeding, like old patient, anybody with history of ischemic stroke, or anyone on the anticoagulant. So this patient, we will try to limit the duration of the APT up to 6 months, shortened to half a year. But this is actually totally based on clinical judgment from our medical team and also cardiologists.
Yeah. I think this more on the cardiologist's decision to decide on the duration of double antiplatelet post-MI, because it also depends on the type of stenting that they use for the particular patient, right?
Yes.
Okay, we don't have any question yet at the moment, but we still got time. Is it possible if you can share with us some of the case scenario that is a real case, right, from our nearest clinic kesihatan, so that we can learn from the case? Probably you can make it this one like okay, slideshow.
Okay. So I have 2 cases to share here. One is from KK Gambang and one from KK Tekit Pulau Tioman. So this is the first scenario. It's a real case. So let me tell you the case. First scenario is a 60 years old gentleman with non-known medical illness, ex-smoker, stopped for 2 years, presented at KK Gambang 9 a.m. with complaint of central chest pain pressing in nature since 7:30 a.m. So the pain was non-radiating, symptom associated with profuse sweating, otherwise no shortness of breath. So upon arrival, patient alert, E4, V5, M6, not tachypneic. BP was 136/85, heart rate was a bit bad, breath is 58. SpO2 was 98 to 99 under room air, and the body weight was 91 kilo. So this is the ECG at the presenting moment. So any takers want to answer the ECG finding over here? Any takers? No takers. If there's no takers, then
you can just pick up any of our postgraduate master student.
Okay.
To have a try.
Yasir. Dr. Yasir.
There is
I think
ST
make it a slideshow so it can be.
sinus rhythm. There is ST depression over the one AVL, V2, V3, before V5, and slightly V6. And ST elevation lead 3 to 3, like ST elevation inferior MI lah. Maybe we can proceed with posterior ECG.
So actually, this is you're right. It's inferior MI. So once you diagnose it as inferior MI, what will be your next step, Dr. Yassin?
Do posterior, posterior atau right, posterior and right ECG.
Unfortunately, I don't have the posterior. You are right, but then, so what will be your next management?
Management for this patient, because patient presented with typical symptom and ECG, like ST elevation, acute Stemi, we can start with aspirin and clopidogrel, oxygen, and if pain, we can give morphine.
So I'll move on to the next slide. Thank you, Dr. Yassin. So this patient is right. He's right. So there's ST elevation in lead 2, 3, and AVF. So this was diagnosed as inferior myocardial infarction. So this patient actually was given aspirin and clopidogrel and sublingual GTN one-tab stat. And there's no oxygen as per Dr. Yassin told because the oxygen was okay and patient was not tachypneic. So then subsequently, patient was given fibrinolytic therapy. So IV methylase 10,000 unit bolus was given and with IV heparin 5,000 units stat. So post methylase, BP was 150/89, heart rate is 60, SpO2 was 98, but the pain score is 7 to 8/10. So let's look to the next after post methylase ECG. So any takers for this ECG? Post methylase ECG. Dr. Yassi, you want sambung?
Navin.
Okay, Naveen. Post-methylase ECG.
So the post-methylase ECG, I can see there's still sinus rhythm and ST elevation over the lead 2 and lead 3 still present. And the ST depression over the previous ECG, I can see still present on the V4, V4, V5. V4, V5. I think there's still there's ST elevation over the lead 2 and lead 3. This is post fibrinolysis 1 hour, is it?
Yes, post-methylase 1 hour.
I think still not successfully fibrolyzed.
Yeah, right. Okay, thank you, Dr. Naveen. So yes, patient actually failed our fibrinolytic therapy as in view of there is no any reduction, not even 50% of reduction of ST elevation in lead 2 to 3. So this patient was further referred to ED and cardiologist for early PCR in view of failed fibrinolytic therapy. So here comes another interesting case, second scenario.
Hold on, Dr. Samni, I just want to ask regarding this first case because patient is from KK Gambang, right? So this patient transferred to PCI center, which is HTAA.
Exactly.
Right. If I'm not mistaken, you mentioned that the timing from our KK to this PCI center must be within, the travel time must be within 1 hour. Am I right?
Yes, that's true.
So I just want to ask, because this patient received fibrinolysis in KK Gambang, and after that they waited for 1 hour for another ECG before, or they actually how their mechanism does actually they wait for 1 hour or they actually transfer patient direct to HTAA?
Okay, usually patients who are receiving fibrinolytic therapy in KK is actually decided by our EP as well. So once we decide and patient is fit for fibrinolytic therapy, we will give the fibrinolytic therapy and we have to monitor the patient up to 1 hour. So if successful, then we have to further discuss whether the patient will be transferred from 3 or 24 hours or must be sent in within 3 to 24 hours for facilitated PCI, which means once we give PCI, patients sustain a resolution in 50%, and we will be sending patients still to tertiary center for facilitated PCI, which will improve the prognosis. But in this case, patient was decided on fibrinolytic therapy first and noted in within 1 hour, there's no reduction, then we will be deciding. So there's another 60 minutes there, actually.
Okay, all right, clear. Thank you.
So moving on next, 53 years old gentleman, non-medical illness, active smoker, 32 pack years, presented to KK at 3 a.m. with central chest pain, sudden onset while sleeping at 2 a.m. Heavy in nature, non-radiating pain lasted for 2 hours, associated with numbness over left upper limb and nausea. So otherwise, no SOB, no palpitation, no diaphoresis, no lower limb swelling, reduced effort tolerance, deny any family history of sudden death or IHD. So upon arrival, the vital sign was stable with a BP 120 over 86, heart rate 72, SpO2 was 99, the pain score was 3, and the body weight was 56 kilo. So this is the first ECG upon arrival. So we'll call someone. Dr.
Maybe final year student.
Final year student. Any final year student around? Sorry. Dr. Zafira is around?
Suddenly we don't have final year student, yeah?
Okay, never mind. I pick
Random.
Dr. Zafira.
So this is the first ECG at KK Tekek Pulau Tioman, right? This is the case from Pulau Tioman. Yeah, okay.
Dr. Fatiha.
Okay. Hi, Dr. Tawani. So the ECG is sinus rhythm. So basically, I can't. This probably ST elevation at V2 V3. So how many box? The small box there, I can't see clearly.
Yeah, but you can see that the J line already
Yeah.
Accurate.
V2 V3.
It's not isoelectric.
Mm-mm.
So your diagnosis, Dr. Fatiha?
Hyperacuity wave.
Hyperacute T.
Yeah, that's normally the early changes of ECG, hyperacute wave. Which lead are you talking about? There is hyperacute wave. Siapa yang cakap?
V2, V3, V4.
Alright, okay.
Anteroceptor.
Okay, then. So you're right. It's an anterior myocardial infarction. So as usual, we will be giving the aspirin 300 stat, clopidogrel 300 mg stat, and this patient was given methylates, 30,000 unit bolus stat, followed by IV heparin 4,500 stat. So this is the ECG in when initiating our methylates. So Dr. Fatia, want to sambung? From the previous ECG, can compare this? This was just before we go to...
This is very clear. This is very clear. Anteroceptor MI.
Yes, thank you. So next 15 minutes.
What's the most obvious finding when you compare from the first ECG and this one? I think it's quite...
So you can see the J point is elevated. So it can clearly seen at the V2, V3, V4, V5, and also V6.
Yes, just now because we see that hyperacute wave is the earliest changes, and now we can see that how the changes evolve from the first ECG.
So when we compare the from the previous ECG, is very clear, very clear changes of the ECG with 2 to V6, and there is no Q wave. I can see no Q wave, and I think so.
Dr. Samani, this certain ECG, is it immediately after receive fibrinolysis or before the initiation of fibrinolysis?
This is exactly when we are going to initiate the methylase after the first ECG.
Oh, okay. So the
Within
next
like
ECG, what happened? 15 minutes or 1 hour?
this is after 15 minutes on methylase,
Hmm.
ongoing methylase.
All right.
Then we can see subsequent further increasing of the ST elevation. And then this is post
like
30
worsening,
minutes. Yes, worsening, doctor. So in ECG in 30 minutes, further worsening of ST elevation, which I think can see already have a deep Q wave. And then
Which
post
one?
1
A
hour,
deep Q wave. Can you show to us deep Q wave?
the V2 to V3.
Okay. Because
And
the
V5
of the wave is more than 25% of the R wave. That's why you consider that as a Q wave, eh?
yes, doctor.
Okay.
So this is totally the ECG post 1 hour post methylase. So here, I think we all aware that there is totally no 50% of any resolution. But surprisingly, the patient pain score post methylase was like from 3 reduced down to 2, but the ECG has no any changes. There's no resolution in ST elevation.
Okay. What happened
So
to this patient after that?
this patient then we actually referred to tertiary center as well. So for a PCI, rescue PCI. So before transfer case was discussed to the consultant cardiologist. So patient was given another second dose of clopidogrel and IV heparin was started, and targets ETA to target PCI center was within 16 minutes. So
Right.
yes.
Dr. Saman, this patient from Pulau Tioman area, right? So how does this primary care at KK level, how do they actually arrange for the transport of this patient to the PCI center?
Okay, usually patients who are away from our centers, we will actually ask a retrieval team to help with this particular KK to come and bring the patient to the hospital. So we have a retrieval team actually that we can contact to help with transportation.
All right. Anything? All right. That's all, Dr. Samani?
Yes, doctor, that's all.
Okay. So do we have any more questions from participant? We have 7 minutes left. Okay, I assume there's no more. Okay, there's a PD point registration. For those who want the CPD point, please register, fill in the Google form. Okay, so if there is no question, I would like to thank Dr. Samarni for your session, because I think this session has truly reinforced our role in primary care for the STEMI pathway. While we may not perform the definitive interventions, but we are the first responder in identifying, stabilizing, and also ensuring rapid referral of this patient. So thank you, Dr. Samani, for your valuable insight, and also thank you to all participants for your engagements. So I hope we can apply what we have learned today in our daily clinical practice. So with that, we close our CME with Tasbih Kifara and Suratul Ra'as. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Sharmani.
Thank you.